morning, everyone. Thank you for the opportunity to be here this morning and talk about Fanconi Anemia, an overview. In the next 30 minutes or so, we will talk about major aspects of Fanconi Anemia as a disease, what are the preventive options available, what are the treatment options available, and then following that, we have each center talking a little bit deeply into the current transplant approaches and current other clinical trials or opportunities that they may have available. So, as we all know that all our cells are continuously sustaining DNA damage, and those get repaired in general, and the damage can be from a variety of insults, as shown here. But anytime there's a DNA damage, basically different DNA damage repair mechanisms get activated. And if there's defect in DNA repair in any of these mechanisms, it leads to chromosome instability syndromes. And the one of the two types that we are interested in is congenital marrow failure syndrome, for which Fanconi anemia is one of the commonest congenital marrow failure syndrome that we all know. Now, as the name suggests, we are born with it, and over time the bone marrow fails, meaning the blood counts drop. Okay, so what does the normal marrow do? First, let's look at that. So normal marrow has stem cells. Stem cells are, can you guys hear me? I'll keep the mic, it's okay. Stem cells are the mother cells, and they're like the seeds. They will form the baby cells that will form the mature blood cells as shown here. So this is the baby cell, the myeloid that produces the neutrophil, the red cells, the platelets, and this is the lymphoid baby cell that produces the B cells and the T cells, your immune system. This is what different types of blood cells look like when we look under the microscope, when the physicians are looking at the blood smear. This is what it looks like. So as we know, Fanconi anemia pathway is a DNA damage repair pathway. So when there is DNA damage, Fanconi anemia pathway also gets activated along with other pathways, and it repairs DNA. If the Fanconi anemia gene or genes are missing, this repair does not happen. And that leads to different things, as we see in the patients. And I know some of this may be a little bit too basic for some of you who are further out in your journey, but I'm trying to address the common things also so that there are new families can benefit from it. But anyway, so Fanconi anemia, this leads to congenital anomalies, it leads to progressive bone marrow failure, and it leads to cancer predisposition. Okay? And we know there are 23 subtypes, and they all, we are running out of alphabets now of the Fanconi genes we have. But the most common ones in the US are Fanconi A, followed by C, followed by G. Okay? And these are inherited, for most part, in autosomal recessive form, we call it medically. But basically, each parent carries a defective FA gene, and then there's one child, if he or she inherits one defective gene from each parent, gets two defective genes, and that leads to Fanconi anemia. Some of the common congenital anomalies and common features of FA that you may have read or you know already and have seen is short stature, some thumb abnormalities, and some facial abnormalities that can be subtle and may not be easy to pick. Upper extremity abnormalities don't just restrict to abnormal thumbs and abnormal radius, but can be any of different things listed here and as shown here. We do see cafe au lait spots, the darker spots, and also hypopigmented spots, the lighter ones as shown here. Kidney abnormalities are common in patients with Fanconi anemia. It can be one kidney which is lower, kidney which is horseshoe shaped like this, you name it. And these can be associated, depending on how severe the deformities are, it can be associated with decreased renal function. So it's important to look at kidney functions and monitor kidney functions in patients who have these problems. Essentially, any of the organ system can be affected by one of the anomalies. As listed here, again, the percentages are listed here, but the important thing to remember is almost 25 to 30% of the children will not have any external abnormalities. And these are the children where the diagnosis may be delayed. Some of them may present as adults directly with malignancy because they were fine, they did not have any problem, they already did a CBC. Okay, the complete blood count is CBC. Please feel free to interrupt. This is camp. This is not a scientific symposium. If you have a question, you can interrupt me. So in theory, practically speaking, we see counts low, but what happens inside the marrow is basically that you have a normal stem cell reserve or near normal stem cell reserve, and these stem cells are hypersensitive to pro-inflammatory cytokines, to other damages. So what kind of damages they are hypersensitive to? So oxidative stress, aldehydes, other genotoxic agents, inflammatory cytokines, chemotherapy, radiation, all of this. So these cells are hypersensitive, meaning they over time will die when they have over and over these insults. And then it leads to lower counts, as shown here, right? So that explains what you see early marrow failure or progressive marrow failure in early childhood. Once you have progressive marrow failure, one of the things to think about it, how does the patient get increased risk of leukemia? When you have fewer cells, your bone marrow is really cranking up and trying to make more and more and more. And in that, to divide, the stem cells have to divide to make more stem cells and more baby cells. And in that somewhere, it acquires some defect. And that leads to and that gets propagated as shown here. So here the ones with the X's they acquire the mutation, and then the normal cell gets proliferated because the bone marrow doesn't know that this is normal or abnormal, and it keeps cranking up. And that's where the risk of leukemia or myelodysplastic syndrome comes from. So basically, leading normal hematopoiesis goes to abnormal hematopoiesis. And what abnormal hematopoiesis means, abnormal blood counts. Decreased production, it can be decreased production of one type of blood count. So decreased neutrophils called neutropenia, thrombocytopenia is decreased platelets, or decreased hemoglobin is anemia. Or over time, it can be all cell lines that are decreased. And again, when the abnormal proliferation happens, you develop pre-leukemia or myelodysplastic syndrome or leukemia. So marrow failure usually starts in the first decade of life. Median time is reported to be 7.5 to 8 years of age, meaning 50% of the patients will develop marrow failure before that age, and 50% will develop after that age. Okay? And usually it's the low platelets that come first, and then followed by lower neutrophil and hemoglobin. Now, it doesn't have to follow the pattern, but that's what usually happens. Severe decrease in all counts happens over time, and it can be months to years. And unfortunately, this part is, painful for clinicians, more painful for you as parents and families and children, because there's no way to predict who's going to progress quickly, who's going to have counts okay for a long time. So that's why you need close monitoring. This is what progressive marrow failure looks like when we do the bone marrow biopsy. So here are all the blue cells, which are small, large, and you can see this large blue cell too. These are the normal hematopoiesis, And this is a marrow that's empty, so anything that's empty, the fat comes in and takes the space. So that's why these are fat cells, and you don't see many blue cells in there. This is what, when the bone marrow happens every year, this is what we are looking for. Myelodysplastic syndrome and acute myeloid leukemia risk is about 20 to 25% by age 40. Again, myelodysplastic syndrome and Fanconi anemia is usually associated with complex clonal cytogenetic abnormality. When we do the bone marrow, we look under the microscope, we do a study called FISH study, we do cytogenetics, meaning looking at the chromosomes and some additional testing. So here we have chromosome abnormalities that are usually more than one or two. So what are the common chromosome abnormalities seen in Fanconi anemia patients? So us and other centers have, this was about 12 years ago, but Germany, us, Minnesota, all of us have independently shown that chromosome 1, 3, and 7 are the commonest abnormalities seen in these patients. Chromosome 1 by itself, as shown here, both the curves are going together, telling you that it doesn't always progress to myelodysplastic syndrome, but it's a start we monitor closely. It attracts other chromosome abnormalities. And one of the other common ones is chromosome 7 or 7 abnormalities. Chromosome 7 abnormalities, which are bad news in non-Fanconi patients also. Same application here for Fanconi patients. When we see abnormality of chromosome 7, that we do a repeat marrow quickly to confirm that it's true, and we don't wait because this will progress to myelodysplastic syndrome for most part. Okay. Chromosome 3 abnormalities not as stark different than like monosomy 7, but over time we've learned that it actually is similar, and that is considered as an indication, again, to move forward with transplant. This is what the blast cell looks like. I've just put the picture there. Here you can see normal marrow is heterogeneous, means shapes and sizes are different, and here it's all cells of one type, so clonal. Common solid tumors. Okay, patients with Fanconi anemia also have significantly increased risk of squamous cell carcinoma of head and neck, vulva, cervix, and in the skin. Okay. A subtype of FA, as you know, FACD1, BRCA2 patients, they usually don't present with marrow failure, but they develop cancers early on in life. Apart from leukemia, they also get neuroblastoma, basically tumor of the adrenal gland, medulloblastoma, brain tumor, one of the brain tumor kinds, and Wilms tumor is tumor of the kidneys. In medicine, we just like to name things more complicated, so it's but this is what it essentially means. Also, secondary solid tumors related to exposure to radiation during transplant is an issue with patients with Fanconi anemia. When you say they are at increased risk, what are you talking about? Overall, 50-fold increase. When you look at acute myeloid leukemia, 600-fold increase. Head and neck squamous cell carcinoma, 500-fold increase. Vaginal squamous cell carcinoma, 3,000-fold increase. So this is not a small number. This is real deal. And what happens is, and again, I'll talk about the therapy and the transplant. Once the transplant happens, we all feel relieved with one piece, but this also needs to be kept in mind and addressed and attended to, is the point. This risk is further increased by 4 to 4.5-fold in patients who undergone transplant. Again, as I mentioned with BRCA2, there are other subtypes that also have increased risk of cancers. My point of bringing them here back is to make sure that we talk about that there's increased risk of cancers in the carriers. in the parents. So if you're a parent of a BRCA2 child, you need to make sure that you take care of yourself too. There are protocols that are in place that you go and talk to your physician, go to talk to genetics, and get your screening in place. It's very important. I'm a parent too, and we just focused on the child, and we're just running and managing, and most of us don't take care of ourselves. But this is an important exception where the risk is pretty high. So again, for the BRCA patients, as I mentioned, because of the tumors, we do imaging every 6 months to 1 year. If insurance doesn't cause trouble, we like to do every 6 months. MDS, AML, these patients get bone marrow more frequently than other FA subtypes. And why it is important in terms of head and neck carcinoma, what is different about FA compared to non-FA? And here's you can see that incidence of squamous cell carcinoma by age 40 is significantly higher. Age at presentation is younger, even without using tobacco and alcohol. These patients also get second primary tumors. If you take care of one, another one pops up. And last but not the least is the treatment is limited. Patients who do not have Fanconi anemia, if they develop head and neck squamous cell carcinoma, they can be treated with surgery, radiation, chemotherapy. Patients with Fanconi anemia have inherent chemotherapy sensitivity, and that's why they cannot, and also radiation sensitivity, so they cannot be treated with normal doses of chemotherapy, normal doses of radiation. So the key is early detection, so that we can cut it out, we can deal with it just with surgery. So that's the importance of monitoring and catching things early. That's the importance why you have to, if there are patients here, they have to go and see Anika in the next room, do the brush biopsies. This is the reason. In general, we have to keep a high index of suspicion because, as shown here, the age distribution you can see goes through adulthood, and there are patients who may present for the first time as adults with leukemia and with solid tumor. So the other thing we have done is we've educated our counterparts at University Hospital, the ENT specialists or the oncology, is if somebody sees a head and neck carcinoma, squamous cell carcinoma in a 30-year-old, they should think that this is not normal, pause, send the patient this way, and they do now. But it took time, but it is important to not start therapy till Fanconi anemia has been ruled out to prevent potentially fatal toxicities. Okay, how do we diagnose? I think a lot of you have read and heard about it. The gold standard is doing DEB testing and mitomycin C. What you're looking at is basically chromosomal breakage with these agents. Then we do complementation groups or nowadays molecular testing to figure out which subtype we have, and then we think about, okay, how are we going to do now? Now that we have a diagnosis, we know about the disease, what are we going to do about it? And it takes teamwork and organization to care for Fanconi anemia patients, and we all know this, we all deal with this every day. This is no news, not new news for you guys, but in terms of clinical care, important that we see a hematologist, and if possible, a Fanconi anemia comprehensive care center visit at least annually. You can then come back and do your things locally. That's not an issue. But so what do we do in general? Specialty care is needed. First thing is congenital anomalies. They need to be addressed. Some of them need to be addressed right after birth, so important. Some of them later. Malignancy screening for MDS and leukemia. What will the patients go through? They will need CBC every 3 to 4 months, and annual bone marrow aspirate biopsy, after 2 years of age. Okay, so every year, and why you have to do every year, even if the counts haven't changed, is because you want to catch those chromosome 3 and 7 abnormalities so that we don't go into transplant with MDS or leukemia. Okay, malignancy screening for solid tumor as listed here. You get annual oral exam and also scopy from the nose and the airway starting at age 10 and then over 1 year after the transplant. Annual gynecologic surveillance after menarche or age 16. And again, I will put in a plug for HPV vaccine. We clinicians and researchers and scientists can keep debating about it, but really, it's your child. Why would you not do it? Just do it. Whether there is controversy, whether HPV is responsible for Fanconi squamous carcinoma or not, doesn't matter. It's just like any other vaccine. More important in our population because there are some clues that it may be doing something, so why not prevent it? Okay. So my child's counts are fine. What will the doctor do? What therapeutic options does my child have? Okay. So as I said, you address the structural and also functional issues related to the anomalies. Early HLA typing, so you know the donor options. Otherwise, up till now, for years and years and years, the only thing was watchful waiting. And that watchful waiting is very easy for us to say, but it's very hard for that side of the room to go through it, to live it. And I'm very happy that now, at least, we have I've been doing this for more than 20 years, and I think last probably 5 to maybe 8 years, we at least have agents that are going into patient, which is so rewarding to see. I'm all about science, I love science, but if somebody is going to fix the mice, it doesn't help me. We need things to come to the patient, and this is very nice that we have prevention studies for early marrow failure. We completed one in Cincinnati on quercetin. We saw a decrease in reactive oxygen species. We saw increase in CFUs, the colony forming units. We saw decreased damage in stem cell compartment, decreased loss, things like that. Metformin study was completed by Boston. They presented their results last year too. And there's an upcoming another agent that is it is through a company, but it will be a phase 1/2, meaning making sure that first, number one, checking the safety first, and then efficacy in the phase 2 of a compound called FP045, which is a human aldehyde dehydrogenase 2. Again, the fancy name, basically it will negate the damage that aldehydes do to the stem cells. And this is being opened in Minnesota, Memorial Sloan Kettering, other centers, and you will hear more about it in the next talks. Okay. Gene therapy, again, Agnieszka will talk about it in her talk in detail, but in general, basically, same thing. Like almost 18 years ago, I sent samples from the freezer to Madrid, to Juan, to when he was trying to do the early gene therapy studies, as just the patient samples that you all sign and donate for research, and they were shipped. And for years and years and years, I mean, yes, we were trying, but it took a long time, but it's finally here. It's in the patient, which is a big, big plus, and things are only going to get better. I think it's a good thing. We're really looking forward to what results we actually see, and how many patients we can apply this to going forward. In general, basically, this picture is from the FARF clinical care guidelines, so thank you. Very nicely depicted. Basically, you take patient cells, you correct the gene, and you put the corrected gene back in the patient. Historically, there have been questions because patients with Fanconi anemia, we did early collection studies in Cincinnati in 2005, around that time, and just for future use, and we and others found that somehow the stem cell collection from patients with Fanconi anemia was not as robust as non-Fanconi other gene therapy trials. there were some questions about, leukemia risk after gene therapy, things like that. Parinda will talk about it in detail with you guys, so I won't go more into it. But I wanted to just give you a brief overview. But these were the things that were now available for early metal failure, which is really good. What if the stem cells are already damaged, or can patients with moderate metal failure be helped? For many, many, many years, we've been using androgens, like anabolic steroids. I don't know why we say baseball only, but apparently, yes, so apparently it's a thing. So I will not argue. I'm learning American ways still. Baseball players use anabolic steroids, okay? But the side effects are still an issue. So it helps with improving the counts. But the side effects, you have to think about it. Nothing in medicine is without side effects. Even Tylenol has side effects, right? So masculinization, not an issue unless you're a girl, but liver damage, benign and malignant liver tumors. So this is an issue. It improves counts or delays further decline on an average for about 2 years, and there's a 50-50 chance that a patient will respond. So usually taken as a bridge when there is no donor, or we're waiting, or we haven't decided that we can go through the transplant. Having said that, I do have patients who have been on it for years, but again, this is something we have to keep in mind and think, monitor closely. The newer androgens do have less side effects, and now we do have monitoring protocols in place, so that we can do this more safely than how it used to be. $1 million question on everybody's mind the moment the diagnosis is made. I just recently on Fridays saw a mother, and we both cried, and this was the question: will my child need a transplant? And the answer is most children with FA will develop low blood counts over time, most. But when the bone marrow failure is severe enough to need transfusions, or there are evidence of pre-leukemia or leukemia, that's the only time we will move forward with bone marrow transplant. We are transplanters, we love to transplant, but we do not transplant patients unless they really need it, because transplant has potentially life-threatening complications. Nothing is 100% in medicine. So why ask for trouble till we really need to? So there is, in general, some people will say outcomes are better at younger age, should we be transplanting everybody right away? And I don't think so, we are there yet. Okay? She's giving me thumbs up for saying this. All right. So currently, remember, bone marrow transplant is the only curative treatment options. They are challenging because of the sensitivity of the chemotherapy radiation, and basically, remember, it cures the bone marrow, but not the other tissues. What if you actually need a transplant? It's easiest if you have a matched sibling donor. What are the chances that your sibling will be a match? 1 in 4 chances. What are the chances that a parent will be a full match? 2%. So not 0. So we've had patients who have parents who are full matches. So that is a good thing. However, what happens to the 75% who don't have matched sibling donor option? And for them, before I go to them, for them you go to unrelated registries. But before I move away from the matched sibling donor transplant, very important what I say I read. Very, very important. We've seen patients coming to us excited, oh, we have a match in the family, we have a match in the family. But they forgot to check the child for FA. So we have to make sure that the child doesn't have Fanconi anemia. Okay? And this is just an example of showing 1 in 4, this patient, and this is identical sibling. If you don't have a SIB donor, unrelated donor registries have millions of donors, and you won't know your donor at least till 1 year post-transplant, but afterwards there is a possibility you can meet. Now transplant, to explain transplant, usually it takes me 1.5 hours consent when I explain transplant to patients, but the one thing that I like, and some of my patients are in the audience and they will know, is compare transplant to the garden. Okay, gardening. What do you do when you have to make a garden? You take the weeds out, you prepare the soil, you put the new seeds in, and you wait for it to be a new garden. Okay? Same thing for marrows that is not working, whether it's due to leukemia. This is a patient of mine who had leukemia. This was my first patient at Cincinnati Children's 20 plus years ago. He had leukemia, and this is permission that I'm posting here. And so whether it's Fanconi anemia or leukemia or anything, the marrow is not working, you kill it with chemotherapy and or radiation. We used radiation in the past, we don't anymore, but you kill it, you make space in the marrow, you give stem cells. The second picture, the nurse is giving stem cells. It goes in the IV, just in the central line. The stem cells go to the marrow, settle down, make a new home, and over time grow into a full new bone marrow. And this is him, you know, at the Reds game, throwing the first pitch. Again, baseball. Anyway, but this is the nutshell transplant. And what is so special about FA? Why are these transplants so hard? And let me tell you this, just two slides on the history of transplant for FA. It started in Paris with Eliane Blackman. If she hadn't started the transplant, none of us would be here. So she is actually the mother of transplant for FA. And they transplanted 5 patients using what they knew the best at the time. And 4 out of 5 patients didn't make it. Why am I bringing this up here? Because this was the first clinical evidence that patients with Fanconi anemia are hypersensitive to chemotherapy and radiation. And they will need reduced doses of alkylators, reduced doses of radiation. So for the next so many years, everybody kept using the reduced doses, but there were still 2 problems: GVHD, graft versus host disease, and graft rejection. Okay. So what do? We use ATG. We take T cells out from the stem cells when the donor graft comes. You pass it through a column, and one bucket you get the stem cells, one bucket you get the T cells. You take the T cells out because those are the bad guys that cause graft versus host disease. That really helped graft versus host disease significantly. Then came addition of fludarabine, highly immunogenic immunosuppressive agent, and it really took care of the graft rejection to a large extent. Okay, it not only took care of the graft rejection, but really improved survival, and that helped us take TBI, total body radiation, out of matched sibling donor transplant setting. Okay, it provided enough immune suppression that we could do transplant successfully in matched sibling donor without radiation, which was huge. However, we were still using it for unrelated donor transplant, but the outcomes improved from 30% to almost 80%. So this is humongous. So after this, the next efforts were into, can we take away radiation from the unrelated donor transplant setting? And Brazil, Germany, they did their own retrospective studies, and we in the US did a prospective multi-institutional study. And I will talk about it in my next talk. But in general, we have improved conditioning significantly to decrease toxicity, including long-term toxicity of squamous cell carcinoma. Okay? Radiation-free transplant, pharmacokinetics, directed personalized chemotherapy, meaning you measure the level of busulfan in the blood and give what is required for a child that is 10 kilo and this tall and has kidney abnormality, or versus somebody who's bigger than me and is a varsity basketball player. And so again, personalized dosing has really helped. Use of antibody with chemotherapy in the conditioning. So you will hear about it from Magnitska. Also, options for cell manipulations. There are more options now for post-transplant and pre-transplant modifications of the graft. Okay? That is to prevent graft versus host disease in every setting, whether it's an unrelated matched graft, mismatched graft, whether it's a half-matched parent graft, which we are able to do nowadays, But so options are CD34 selected T-cell depleted graft. So Cincinnati, Minnesota, Memorial, we've been using this for more than 30 years, almost 25 to 30 years, more than 30 years for sure. More recently, alpha beta CD19 B-cell depletion has caught some attention based on data in leukemia and based on adult data in leukemia and in children also in leukemia and other non-malignant disorders. However, we will hear more about it from Agnieszka. Late complications of transplant, can't forget, always that's why you need to still go to the doctor after the transplant is done. Organ toxicity, endocrine problems, hopefully not if you have chronic graft-versus-host disease, and again, the secondary malignancy. Patients with FA are at increased risk of secondary malignancy because baseline predisposition, exposure to chemotherapy, radiation, and also during transplant, oral and GI tract mucositis, inflammation, sores, and also if you develop chronic GVHD of the mouth. So any physical insult also predisposes to the second cancers later. So that's why long-term follow-up is critical. It's not optional. At least annual follow-up at FA Comprehensive Care Center, early detection, prevention, go see ENCA every year, every 6 months. Frequency of ENT and GYN and screening are listed here. If there are adult patients here, no alcohol, smoking, tobacco, I tell them I sound like their mother when I see them. But I have to say it if I see them in clinic and if they're of the age. Safe sex, HPV vaccine, very important. Novel options for prevention of squamous cell carcinoma. And so we have a study of quercetin at Cincinnati, and I will talk about it in my next talk, but I just want to mention here. But in general, as you can see, it used to be just one more thing on that box when I started, and now we are doing more things in diagnosis, more targeted therapies at early marrow failure, end-stage marrow failure. We have transplant has improved significantly, and I want to draw your attention to the last box, is the prevention and treatment of squamous cell carcinoma, so quercetin. There are repurposing of the drugs that we already know. Jordi, my friend in Barcelona, he's doing the definitive, and we are going to do this here. Novel ways to give radiation. If one develops squamous cell carcinoma, how can we at least make it palatable and still give it? Is proton therapy going to be something that is going to be helping these patients? Immunotherapy. We can't give chemotherapy, but we can give immunotherapy. So immunotherapy is going to be more upfront in our population because of our limitations, but this is something that is coming or is here already actually, and we're doing it, but something to keep in mind. So in general, I've tried to address, the goal was to answer all